Morena Tato, and welcome to this presentation about a new oral history project in the New Zealand context. This is an important day in my own biography as it's my birthday, so I present to you virtually amid celebrations planned for later today. I'd like to give thanks to the traditional owners of the land on which we're meeting, which is the cyberspace for me, but Launceston in Tasmania for you guys. In this presentation, I'll be covering the following material: introducing you to the members of the team, explore the context of abortion care in Aotearoa New Zealand, talk about the aims of the project and what they were, describe the methodology, having had Lynette Shum discuss earlier what that methodology was all about, and then discuss the themes that emerged from the oral histories gathered whilst we became challenged by the context of the COVID-19 pandemic. So we'll go into the various dilemmas faced. Finally, once I've brought you up to speed where we're up to at the moment, we'll look at what's still to do. Originally, we were more than the team members involved currently at the start of the project, but that whittled down to this loyal team as follows. Lynette, you've already met in person at the conference. We had Chris Hanna, who's a midwife from the Te Rāwhiti area, talk about her rural clinic. There's myself, Dr. McDonald, and Nergis Narayan from Tamahoi Clinic, the regional abortion service clinic, which is based at Wellington Regional Hospital. Initially, the plan was to interview the doctors, nurses, midwives, counsellors who were the original clinic employees in the two geographic sites, one urban in Wellington at Parkview Clinic, then it became Level J and now Tamahoi Clinic, and one rural site, abortion services in Gisborne. Later, I discovered that prior to the clinic structure in New Zealand, there was a women's network called Sisters Overseas, also known as SOS, who assisted women to travel to Australia for abortion services in Sydney and Melbourne. The project grew from the providers of abortion care then to those health advocates who facilitated access to women's services in abortion care. And that Trans-Tasman partnership still continues with the Marie Stopes clinics in Melbourne. This was the aim we set out with, to capture and document the development of abortion care from the providers' perspectives. This needed to encompass a multidisciplinary approach with nurses, doctors, midwives, administrators, social workers and counsellors helping each other as trailblazers in a new service starting from the 1980s. The project was sent for ethical approval within our employing hospital and to Victoria University of Wellington's Research Ethics Committee. Both committees approved the project, and we then completed our training in oral history collection at Alexander Turnbull Library. And as I said, Lynette Shum trained the original team when face-to-face training was still possible. To advertise the project and recruit participants, we invited members of APGAN, Abortion Providers Group Aotearoa New Zealand, to make contact with us. Later we found the structure prior to the clinic structure in Greater Wellington. So there were still abortions happening within the hospital in the 1970s, where women were transported to Auckland for the day, for day surgery. We did manage to interview participants keen to remove masks, as the rustling sometimes impaired sound quality of our recordings. There are a number of common themes from our histories, the first being an experience of being stigmatised for the work one did in abortion care. And to illustrate that theme, I'd like to play a recording from one of the interviews, the oral histories recorded with Hazel Irvine, a nurse midwife and later manager of Parkview Clinic.
I can certainly say that I was aware of the need for a woman to have a choice about abortion before I even started any of my health professional training. My own mum became pregnant at around 40, was quite soon after we came to New Zealand. She was very distressed at the idea of our fourth late child and approached the doctor for abortion and was told that she would get used to the idea. She was desperately upset and enraged by this and made it really clear to us as a family that women should have the right to discontinue a pregnancy if they decided so. And I often wonder, she actually ended up miscarrying prior to 12 weeks, and I often wonder if she would have done something about it herself had that miscarriage not occurred, and would I have lost my mum to a botched abortion, because at that time we were all aware that abortions happened, but women often died because, apart from being available to the very rich and privileged in the world, abortion was not legally available and often done under very risky and unsafe circumstances. So
that very powerful account talks about how the personal becomes professional. There's a stigma for abortion care for the workers running through the international literature. Later abortions are potentially the most stigmatising for the woman and for the provider of care. And so what to tell people about your work was problematic, leading to quite a lot of secrecy and the big reveal, causing various kinds of fallout, including criticism and withdrawal from the public view. This excerpt from an interview with one of the pre-assessing doctors, Dr. Rob McElroy, illustrates some of those themes.
There was no problem. I tended to not let people know where I was going. I just said, first of all, where are you going now? So I'm just going up to the women's club. Okay. So you didn't quite know what people's reaction would be if you told them what you're actually doing, because you don't know whether they're pro or anti. So
another common theme was dealing with protesters outside the clinic with placards, interfering with you when you got out of the car and tried to get to work. There was one account from a senior counsellor about having a tradesman who was painting at her house, who phoned her by chance at work and found out where she worked and proceeded to withdraw his men from the job. And a nurse talked about protesters coming to her home to sing carols outside her home at Christmas time as some sort of protest. So there were lots of things to contend with. Another of the themes was the importance of collegial and family support. The main protective factor for keeping going in the work was having good support at work and at home. And at least in these contexts, participants felt trusted and safe regardless of what happened in the public view. This quote is from a counsellor's life partner who was a social worker. She had changed career from police work to training to become a social worker, and then she went on to lead a team of abortion counsellors. She met her husband during her training, who had also become a social worker, and unfortunately he had just passed recently, so she was still grieving for that important loss. Another counsellor recalls fondly the many gatherings and social celebrations that meant they became family to one another, and that was critical to keeping going with the work. One counsellor talked about Parkview Clinic as a great group of committed women with a shared philosophy, which was often feminist in its worldview. This quote from someone who went on to work as a senior counsellor talked about the importance of the calibre of the professionals who worked at the clinics. Oops, back.
We did our very best to get women in the earlier earliest as possible. And what made it work really well was the calibre of people working there. We had good management. We were well linked in with women's health. We had 2 of the doctors who were involved in the 3-person management team. They were committed to the service for women as well.
There were other experiences where friends and family didn't agree with what the worker was doing, and one person talked about a school friend found out about her work and cut off from her, which was quite a sad thing. Another of the themes was a move to social and political activism, important. Women wanted to know more about who their doctor was and to make more informed choices about which procedure. I've included there a film that focuses on why human rights perspective is helpful in abortion care, which you might like to refer back to. This was a comment made by an SOS member. We have to challenge white men deciding what happened with a woman's body. There was also comments about backstreet abortionists having good intentions, even though things didn't go down well necessarily in the final analysis, but many felt they were demonised when things went wrong. Our own COVID challenges were that many of the historians became sick with COVID as the project progressed. Recordings were paused when that happened. There were further local lockdowns in Auckland with travel restrictions to Auckland, and my honorary research partnership with Aotearoa University fell over because of budgetary constraints, so I found myself with no funding, and we needed to apply again for grants. But we did find 2 funders of our grant from other sources. Participants were afraid of getting COVID, so we had to be very sensitive to when they felt able to participate. And we had 2 team members dropped out after too many unpaid hours involved in the project. And so I've included a few references there, but basically that's it. And I hope you have a wonderful conference.